Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to the ANA presentation of Life After AN Treatment, Post-Surgical Complications and Quality of Life with Dr. Enrique Perez of Mount Sinai. This webinar is being released as part of our Membership May, so thank you to all of our current members who helped to make the ANA community what it is. If you'd like to become a member and learn more about all of our member benefits, including webinar library, peer mentors, and more, visit anausa.org. Our website is a great resource for so many topics you may have an interest in, and there's a search function so patients can find just what they're looking for. Lastly, keep an eye on all of our social media pages for more information and resources as well. The ANA is here to help, so please access those opportunities. So Dr. Perez, if you'd like to turn on your camera and introduce yourself, we can get started.
Okay. Hello, everyone. My name is Enrique Perez, and I'm going to share my screen here. I am a full-time practicing neurologist, fellowship-trained neurology school-based surgeon here at Mount Sinai Hospital. Also the director of otology at the main campus. I want to thank the ANA for giving me this opportunity to speak to you folks about quality of life with vestibular schwannomas. And we'll also actually be discussing subjects regarding all three treatment and management options with vestibular schwannomas. All right. So I have no disclosures related to the content of this lecture. And this is a brief outline of the topics we're going to hit. So briefly, we're going to be reviewing the history of vestibular schwannoma management to put everything into perspective of where we are today. Going over some important outcome measures that we look at for trying to decide what treatment option is best for each individual patient, and then transition slowly into the subject of patient-reported outcomes and quality of life measures, and some newer interest in decisional conflict and the role of shared decision-making and how this all translates into decisional regret with trying to decide over which is the best management option for each patient. And briefly touch on some future directions at the end of the lecture. So again, I thought I'd start with a quick overview of where we started and where we are today. Really, when we look back at the early 20th century, the majority of cases of vestibular schwannomas presented with disabling, life-threatening symptoms due to brain compression by very large tumors that had, of course, gone undiagnosed for a long time. This is not surprising. In those days, we didn't have the availability of MRI machines, which today provide an easy way to diagnose these patients. And at the time, the only treatment option really consisted of surgical attempts at debulking the tumor to try to decompress the brain and brainstem in hopes of preserving life, really, which is the main goal of these procedures. However, as you can imagine, these surgeries carried a very high rate of morbidity and mortality, with up to 70% of patients unfortunately dying while undergoing the procedures. In the 1910s to 1930s, we saw a significant change and improvement in surgical outcomes with refinement in surgical techniques by Dr. Dandy and Dr. Cushing's, two very prominent and famous neurosurgeons of the time. These led to improvements in approaches to the tumor and surgical techniques for debulking, and overall translated to reduced mortality rates. However, these surgeries still carried significant morbidity, and it was almost a given that any patient undergoing this type of procedure would probably come out with full facial paralysis, if not some other form of cranial nerve dysfunction, such as swallowing issues or voice problems after surgery. It was not until the 1960s and 70s that we saw the next major breakthrough in improvements in outcomes, particularly for surgical management of vestibular schwannomas. And this came from the introduction of the microscope and the operating drill by Dr. William House, who many of us call really the father of our field in neurotology, and Dr. Delgado, who introduced the use of facial nerve monitoring intraoperatively. Together, these novelties led to significant further reduction in mortality, but also improvement in overall morbidity. It became more commonplace for patients to have preservation of their facial function postoperatively. And even more, we've started seeing patients also retain some serviceable hearing after surgery, which was really an afterthought in previous decades. In the 1980s, the introduction of radiation treatment as a viable option for management of vestibulocinoma became pretty widespread. And in the following decades to where we are today, we have come to really understand how important this option is and how efficacious it could be, particularly for small to medium-sized tumors. As we know, a great majority of them do respond well to radiation. And again, with the ultimate goal of halting tumor growth so that no functional issues arise. Furthermore, around the same time, MRI machine became widespread and became very available for diagnosing patients. And so with this, we began seeing patients getting diagnosed with tumors at a much earlier stage. So we also began to learn a little bit more about the natural history of tumors that were being observed through serial MRI imaging, and understood that the majority of vestibulociniomas actually grow at a very fairly slow rates of 1 to 2 millimeters per year. And some of them may not even be growing at all for several years in a row. So with that, we began to understand that a lot of patients, especially those presenting with pretty small tumors, could easily just be observed as a third management option aside from surgery and radiation. So now, today, we are presented with this kind of scenario where the majority of newly diagnosed vestibulociniomas do fall under that range of small to medium-sized tumors, where all three options really are available to most patients. And so how do we try to start teasing out whether one option is a little better than the other for one particular patient or another? And that's where the extensive emphasis has been in the research looking into outcome measures in vestibulocinoma management across these three management modalities. And so one of the first outcome measures that we obviously always think about is hearing. And this, hearing loss lends itself well to studying as an outcome in vestibulocinoma management, because we have very good objective standardized means for looking at hearing loss over time in this patient population through the use of audiometry, or in other words, hearing tests that you could obtain in ENT office. Also, it's important, obviously, because up to 90% of patients with newly diagnosed vestibulociniomas present with some form of hearing loss on the same side as their tumors. And closely related to this, of course, is tinnitus, which up to 60% of patients will present with this symptom on the same side as their tumor. So to try to understand this data that I'm going to briefly go over with you guys, it's important to have an understanding of the definition of serviceable versus non-serviceable hearing. So when we think about serviceable hearing, really what we're saying is a patient has either essentially normal hearing or some degree of hearing loss that still could be aided with a hearing aid. In other words, the hearing loss is not so severe that if you just place a hearing aid in that ear can still be functional for the patient for day-to-day communications. And of course, non-serviceable hearing, as it sounds, is when the patient has hearing loss that deteriorates to a point where a hearing aid is no longer helpful. And so this data came out not too long ago from the Congress of Neurological Surgeons, and it was a publication that was meant to be sort of as a guide for clinicians to discuss their risk of hearing loss with newly diagnosed vestibulocinoma patients, particularly in that small to medium-sized range. And so when we look at a group of patients undergoing surveillance or observation as a primary management option, when you group together all patients presenting with serviceable hearing who start undergoing surveillance observation, after 2 years, the risk of turning from a serviceable to a non-serviceable hearing status is up to 25%. And this is represented here by this left upper and lower diagram. As you can see, let's say this is a patient who has left-sided hearing loss from a tumor. At this stage, this hearing loss could easily be corrected to some degree with a hearing aid. However, if it drops to this level, unfortunately, a hearing aid is no longer helpful. And as I mentioned, even up to 25% of patients who are just being surveillanced with serial MRIs will unfortunately drop to this status. If we look a little closer at a group of patients with completely normal hearing or close to normal hearing at presentation, as you can see in this upper right diagram, and follow those patients, they also tend to drop to a non-serviceable hearing status by up to 25% at the 2-year mark. Looking overall at more long-term, so let's say you follow these patients 5 or 10 years out, what we're seeing is that unfortunately, there is a pretty significant degree of patients who do drop to the non-serviceable hearing status, whether they presented with normal hearing or some degree of hearing loss that was serviceable, as you can see here, at a 10-year mark and at a 5-year mark for the group with normal hearing. So unfortunately, long-term data demonstrates that even in patients with small tumors that may or may not be growing, we observe them long enough, and unfortunately, the hearing could deteriorate over time at a significant pace. So how does this compare to radiation and surgery? Similar statistics were done looking at patients who presented with serviceable hearing prior to radiation, and it was found that at 2 years out after radiation treatment, up to 50% unfortunately do drop from a serviceable to a non-serviceable status. And at 10 years, similar to the observation group, up to 75% will drop to a non-serviceable status. Once again, looking at the particular cohort of patients with excellent, almost normal hearing, initially they have a little bit of a benefit in hearing preservation, with only 25% dropping to non-serviceable at 2 years. Unfortunately, again, even that group, after 10 years, up to 75% may drop to a non-serviceable status. And now, what about surgery? So similar analysis demonstrated that surgery definitely carries a more upfront risk to hearing loss, and that's something we always discuss with our patients. Up to 75% of patients that at presentation have serviceable hearing will unfortunately end up with a non-serviceable hearing status immediately after surgery. So there's quite a high risk of hearing loss intraoperatively. 10 years out, the numbers are pretty similar, with up to 75% of patients still in the non-serviceable status. In patients that do have excellent hearing initially before surgery, they also do have a slight benefit. Usually it's because most of those tumors are pretty small and possibly easier to dissect, and that's part of the reason their hearing is so good initially. And so when we go in and remove those tumors, we have a little bit better chance of preserving serviceable hearing, with only up to 50% of patients dropping to non-serviceable. However, once again, follow these patients long enough, 10 years out, unfortunately, up to 75% of them will drop to non-serviceable. So I know that was a little bit of a lot of information altogether, but in summary of what I just mentioned, when it comes to hearing as an outcome measure, what we know is across the 3 modalities for management of vestibuloadenomas, initially, there are some differences. Clearly, surgery carries the highest upfront risk, followed by radiation, followed by observation. However, unfortunately, long-term enough, we do understand that all 3 management strategies actually don't differ that much from a hearing status. So what about facial function? Similar to hearing, we have very nice objective ways of measuring facial function. And so it lends itself well to studying in terms of the degree of facial dysfunction depending on the management strategy. And so one method that we use for this is the House-Bragman scale, which has been used for many, many years now to describe the level of facial dysfunction from some level of paresis or complete paralysis. And this is what this small diagram shows here. There's 6 grades to the scale, 1 being normal, 6 being complete facial paralysis. And there's some slight little important differences when you jump from one to another that I won't get too into, but needless to say, of course, if you're closer to the 1 and 2 level, your outcome in general is considered to be good. So how is facial nerve function overall related, to current day presentation of vestibuloadenomas? Well, still to this day, up to 6% of patients with newly diagnosed tumors will present with some level of facial paresis, if not paralysis. Something a little bit along the same lines, up to 12% of patients will also present with facial numbness. However, keep in mind that this is secondary to a different cranial nerve, the trigeminal nerve, which gives sensation to the face. So they may have some numbness or some pain in the face at presentation. Of course, this is much better than back in the early 20s, with the majority of patients likely presenting with facial paralysis due to very large tumors. Now we don't see that as often. So again, using this outcome measure as a way to compare the treatment options or the management options, how does observation play out? So overall, we understand that observation does not pose a risk for facial function. And this is likely due to the fact that most tumors that are undergoing observation in the first place are probably pretty small tumors that are growing slow or not growing at all. And so, of course, the risk for facial dysfunction in some tumors of that category is extremely low. But now, how does radiation and surgery affect this outcome measure? Data looking at facial nerve function in patients up to 5 years out from radiation treatment has demonstrated that really the outcomes are pretty excellent, with 5% or less patients ending up with significant worsening of their facial function, or the way this study categorized it, a deterioration of 2 or more scores along this House-Bragman scale from where they started. And also whether they're being categorized as having some baseline asymmetry, which is really where you start seeing, level 3 and 4 on the grading scale. And so how does surgery compare? So of course, when it comes to surgery, we really have to take into account that tumor size makes a big difference. In general, with small to medium-sized tumors, the current status of surgical techniques and how we manage these tumors intraoperatively with facial monitoring, et cetera, we've ended up with great outcomes in terms of facial function, again, in the small to medium-sized tumors, with greater than 90% patients having preserved House-Bragman 1 or 2. Again, these are the good outcomes. However, again, with tumors that are much larger, we're looking at 3, 4, maybe even 5 centimeters, which are considered giant tumors. That number drops with only 60% or more patients retaining a good functional outcome when it comes to facial function. And as I mentioned in the beginning, how does facial numbness relate to this? Well, in general, again, this is usually due to some impingement of the trigeminal nerve by a tumor. And so for that reason, usually surgery tends to carry a more favorable outcome in terms of reduction in pain from trigeminal irritation or numbness, because you're able to decompress the nerve by removing the tumor. And radiation, of course, is not going to allow for that. So I'm not including here another slide on an important outcome measure, which is really tumor growth or tumor control, because in general, that's something that really is followed more by the treating physician per se. It may not necessarily be associated with symptomatology. But it's important to understand that, of course, we also look at that to compare outcomes between observation, surgery, and radiation. And once again, when it comes to the small to medium-sized tumors, we do feel that there isn't too much of a difference in terms of tumor control between these 3 treatment modalities. So now this brings me to outcomes that are a little bit less tangible, right? Not as don't have as easy of an objective way to measure them, which are, for instance, dizziness and headaches or pain. And these rely mostly on patient-reported outcome measures, or in other words, questionnaires or surveys that the patients fill out to try to assess how disabling these symptoms are for patients. So when it comes to dizziness, there is a standardized and validated questionnaire, the Dizziness Handicap Inventory, that's widely used throughout the field of neurology or otology for all sorts of vestibular or dizzy-related conditions. And that's been used widely to try to study the vestibular schwannoma patient population and understand the differences between the management options. It's important to look at because vestibular symptoms, whether it's imbalance, dizziness, or vertigo, are present in up to 60% of newly diagnosed patients. There's some controversy as to whether tumor size matters. It's been shown that even small tumors can cause significant dizziness, and surprisingly, some larger tumors may not be as symptomatic and vice versa. Studies have observed when comparing the different management modalities that between 30 and 65% of patients with vestibular schwannomas experience some varying degrees of ongoing dizziness, regardless of the management modality. So not really a major difference. Also important to understand is that up to 60% of patients, again, across treatment modalities, but particularly for observation as well, will still report some level of dizziness 8 years out from whether it's the beginning of their observation period or their surgery or radiation treatment. So what does this tell us? That, you know, it may be that dizziness, the quality of it changes over time, or, you know, the frequency, et cetera. But overall, when we're trying to ask patients to report on their dizziness, unfortunately, we're seeing that, you know, there isn't too much change in that symptom pre and post long term, and across all three. So again, this is really emphasized again in this slide. Observation does not appear to confer a difference in long-term dizziness compared to the other two modalities. Some other interesting findings in the radiation literature. It has been demonstrated that sometimes smaller tumors, in fact, may lead to a higher incidence of acute vestibular symptoms immediately after the radiation treatment in the first 6 months or so. And pre-existing level of dizziness, so if may also be, you know, correlated to the degree of dizziness immediately after treatment. So an example of this is you could have a patient with a fairly small tumor, let's say, you know, 1 centimeter in size or less, that could be very vertiginous or very dizzy, undergoes radiation, and acutely they may even get slightly worse. And, you know, unfortunately, they're probably not going to get much better from a dizziness standpoint, according to this data. Surgery results in a higher incidence of acute vestibular symptoms immediately post treatment. And however, important to note, surgery, when we think about dizziness, we're removing the insulting factor, which is the tumor itself. And the hopes is that we've always thought that by removing the tumor, the patient will be allowed to compensate faster. And compensation really means that by doing some vestibular exercises and just, you know, moving around in general after treatment, the patient will start compensating by using the contralateral side and other senses in general to improve their dizziness or their sense of balance. And so it is thought that surgery tends to allow for faster compensation. So although like radiation, you may have an initial onset of worsening dizziness or imbalance immediately after surgery, you may be able to return to a better baseline faster, particularly also in patients who may undergo ablation treatments even before their surgery. This is just a side topic, but basically it's been demonstrated in the literature that some patients can undergo gentamicin injections in their ear with the thought that this will destroy whatever residual vestibular function or balance functions in that ear prior to their surgery, in a way to allow them to start compensating even before they undergo surgery, so that they can return to a better state faster after their treatment. Nevertheless, again, despite this common belief that surgery may carry a benefit in the more immediate post-treatment time frame over radiation or observation, once again, if you follow these patients long-term, 8 years or so, there really isn't, unfortunately, much of a difference between the surgical group and the radiation group. Another important point I wanted to bring up here is that the presence of pre-treatment headache prior to the surgery carries a greater risk of long-term dizziness after surgery. So important to discuss this with your patient, with your physician. If there's any history of migraines or uncontrolled headache disorder that may actually not be associated with a tumor even, these patients tend to have poor dizziness handicap scores long-term after surgery. One last comment about dizziness in general is that remember that a lot of patients with newly diagnosed vesicular carcinoma are really in that 6th or 7th decade of life, where it's expected as we all age that our vestibular function is going to decrease over time. So it's possible that the fact that we're seeing that long-term, the majority of patients, whether they undergo observation, radiation, or surgery, still report, dealing with a little bit of issues, balance, and maybe motion sensitivity. It may just be the fact that their only good side, which the untreated side, for instance, may also be deteriorating a little bit just from age-related loss of vestibular function that now is posing greater dysfunction for the patient. So moving on to headaches as an outcome, similar to dizziness, headaches is really, how do we assess for that? Through patient-reported outcome measures or questionnaires, and one standardized and validated questionnaire is very useful and used often in neurology research is headache disability index. Similar to the DHI, it's a questionnaire that gives us an idea of the level of disability in patients. We know that at presentation, vestibular carcinoma patients, and particularly those with tumors in the small to medium range, do not differ really from the general population in their overall headache disability. However, larger tumors tend to present with more headache prevalence. Observation may lead to increased headache burden compared to the general population over time. So this is an interesting point. Even if the tumor may not be growing, if it's pretty small and it hasn't shown much growth or is growing pretty slowly, unfortunately, by following these patients long enough, we do see that there's a trend towards increased frequency of headaches as it compares to the general population. And looking at long-term outcomes, when it comes to, again, headache disability, we're once again not seeing much of a difference between management through observation, radiation, or microsurgery. In the short term, again, surgery seems to be the most problematic. In the first year or so, patients will report significantly higher disability from headaches when compared to observation or radiation. This is not really surprising. Surgery by itself carries a risk of just post-surgical headaches from craniotomy. However, the good news is that this does tend to last a fairly short period. In that first year post-surgery, the majority of patients will get better. And this lower bullet point here describes in general what our experience is, with 25% of patients not really requiring any medication, up to 65% maybe requiring some anti-inflammatory medications like ibuprofen, non-steroidal medications, and just about 10% requiring stronger medications to deal with that initial uptake in headaches. There are some predictors of long-term headache disability, which include young age, female gender, pre-existing headache history, and overall anxiety. Interestingly, however, these same factors are also risk factors for headaches in the general population. So finally, moving now towards the rise of disease-specific quality of life outcomes. We've been describing very specific outcome measures. And really, when we're looking at quality of life questionnaires, what they're trying to do is attempt to group all of these together to get an overall general assessment of a patient's quality of life with either treatment or observation. And so when it comes to vestibular for many years, really what we were using were non-disease specific quality of life measures, such as the SF-36, the PROMIS 10, and the GBI. These are just questionnaires of overall health as it relates to quality of life. However, in the more recent decade or so, we've seen the rise of disease-specific questionnaires for quality of life that are specific to vestibular schwannoma patients. And this is, of course, the Pan-Acoustic Neuroma or Pan-QOL questionnaire, and the more recent vestibular schwannoma quality of life index. So in 2010 was when the first publication came out of the Pan-QOL, when it was validated by the PAN group. Again, the reason for this was because it was noted that the most commonly used SF-36 questionnaire was not very good at differentiating vestibular schwannoma patients from non-vestibular schwannoma patients. And so the Pan-QOL was much better doing that than the SF-36. And what is the Pan-QOL? It's essentially a questionnaire with 26 items, each scored from a 1 through a 5, 1 being strongly disagree, 5 strongly agree, for a total composite score of 100. So these are just some examples of what it asks. I feel steady or off balance or lacking energy or vitality. All 26 items are then grouped into 7 separate subdomains for hearing, balance, face, anxiety, energy, pain, general health, and of course a total quality of life score, which is obtained separately. Furthermore, this is another important point to make when we're looking at the Pan-QOL scores. It became important to understand whether differences in these scores when comparing, let's say, two management options such as observation and surgery, as studies started discovering statistical significant differences between these management modalities in the scores that patients were reporting, we started asking the question, well, how important is that difference clinically? So this is where the concept of minimal clinical or clinically important difference comes up. And what does this mean? Essentially, well, in a questionnaire that is scored out of a score of 100, if one group differs from another by 5 points, and that is statistically significant, well, is that really even a clinically significant difference for patients? And so MCID studies were performed to try to understand really what that cutoff was, where we would say, well, the difference in these two scores is clinically significant. And so these are the MCIDs for each individual score. For the total Pan-QOL is 11, and then for each individual domains for hearing, balance, facial pain, energy, anxiety, and general health. So with that in mind, this is just a brief overview again of studies comparing the 3 management options, looking at using the Pan-QOL and specifically the MCIDs for the Pan-QOL to try to determine, once again, is one management option better than another? Again, keep in mind that this is mainly focusing on patients with smaller to medium-sized tumors where all 3 options are viable. So what do we know? In the short term, first 6 months, these are pertinent findings. So for the facial domain, it appears that the surgery group does have worse scores than the observation and the radiation group. And not just the surgery, but also surgery plus radiation group. So this is a separate, you could almost think of it as a 4th management option, which is patients that unfortunately undergo surgery and maybe end up having a subtotal resection, probably for hopes of preserving function, who then end up having further growth of the residual tumor that requires radiation down the line, or vice versa, a patient who undergoes radiation and falls under that small group of patients that unfortunately fails radiation treatment and ends up requiring surgery to manage a growing tumor down the line. So it's a multimodality treatment group. What we know is that both the surgical group and that group seem to score worse in their facial domain when compared to observation and radiation. From the hearing domain, scores appear better in the observation group than the surgery or radiation and multimodality groups. For the anxiety domain, the scores, was a very interesting finding. The scores are higher in another cohort of patients that was looked at that we called management naive. So what does this mean? It was a group of patients who had just been diagnosed with sebaceonomas. Let's say they had just gotten their first MRI and went for consultation, and yet had not yet decided on what management strategy would be best for them. They were in that first 6-month period before their next surveillance MRI to determine whether they were just going to continue to undergo conservative observation or decide to undergo radiation or surgery. And so what was found in this study is, interestingly, that within this anxiety domain, these patients actually scored significantly worse than patients in the surgical group and patients in the observation group, not so much in the radiation. But overall, what's the take home from that is that there's a significant level of anxiety associated with just the diagnosis of the tumor, and not so much even once you obtain a strategy for management. And so it's important to address that during those initial consultations with patients. And then importantly, while not achieving that cutoff for the MCID value, it was still pretty significant. It was statistically significant in the energy and general health domain, that there was a difference with better scores in the observation group than the, again, management naive group. So overall, it seems like this initial 6-month phase after diagnosis carries quite a high rate of anxiety, feeling of general poor health, and fatigue in general. Probably patients thinking so much about their new diagnosis and what the future may carry. And long-term findings, looking at longitudinal and cross-sectional studies, these are some of the points that I thought would be useful to touch on. So for the total PanQOL scores, again, there's not a significant difference between all 3 management modalities. So this is 10 years or more out. Patients are provided with the questionnaire and asked overall, what is your quality of life? We are finding that, once again, observation, radiation, and surgery at that time point are quite similar for just overall quality of life. And also from a longitudinal standpoint, so what does that mean when we look at patients across a period of time? So you provide them with a survey at one point and then wait 10 years later, provide them with a survey again. We're finding that the scores are quite stable despite individual differences. So yes, there's a group of patients that are going to deteriorate in their overall quality of life, but equally and opposite, you have a group of patients that will improve in the quality of life, while the great majority of them sort of maintain a similar level of overall quality of life. And then again, some further findings in the balance subdomain, scores for surgery and radiation being worse than for observation. And in the anxiety subdomain, worse for radiation than for observation. There was also once, reverting back to this group of radiation plus surgery multimodality, it was demonstrated that even at long term, their quality of life scores are worse than the observation group. And unfortunately, their scores tend to decline over time. So again, this stresses the importance of trying to really manage patients as best as possible in order to avoid, as best as possible, the need to do multimodality treatment. Of course, there are times that this is sort of out of our hands in very large tumors that, for instance, may not be able to get fully resected and end up requiring radiation down the line, etc. So one final comment, no reliable predictors were found for improvement or deterioration in overall quality of life. So looking at age, patient education, et cetera, all those kinds of demographic values were not significant. So not all subdomains are created equally. So remember, we started our discussion with outcomes looking at hearing loss and facial function. Well, as it turns out, again, as you recall, there's 7 subdomains in the PanQOL. It turns out that dizziness and headaches may actually play a bigger role in overall quality of life than hearing loss and facial function. This is actually a pretty interesting finding, almost like a paradoxical. Patients are thought to care most about their hearing and their facial function, but when we really analyze the data from quality of life studies, we're finding that really dizziness and headache disability tends to be the biggest drivers of overall quality of life. And of course, when we look at the PanQOL, they're weighted similarly between all 7 domains. And in fact, the domain of pain or headaches almost seems that it's not given enough attention in the PanQOL, with only 1 out of those 26 questions in the survey addressing this concern. Lack of energy and anxiety also appear to be pretty strong contributors to overall quality of life. So shifting gears towards the latter part of this talk, it's the discussion of decision-making. So, and how that may have an impact on quality of life. And I'd like to start with this quick diagram just to, as a take-home message here, there's a lot of decisional conflict that goes around deciding which of those 3 management options is best for each patient, of course, from the patient side. So this is just a quick schematic of an example of how many variables go into deciding whether observation or radiation or surgery may be best for one patient or another. So not surprisingly, this leads to a lot of decisional conflict in patients. And what is that? It's the difficulty patients experience arriving at a management decision regarding their health. There's very limited data regarding this decisional conflict in patients with newly diagnosed vestibular adenomas. However, there was a study not too long ago with a cohort of 77 patients with all size tumors, and it was found that up to or close to 1 in 4 patients demonstrated significant levels of decisional conflict as determined by a validated decisional conflict scale. The perception of shared decision making, which was also studied in this study, is negatively correlated with decisional conflict in vestibular adenomas. So what does that mean? Again, if patients believe that they had adequate shared decision making with their physician, overall decisional conflict goes down, and vice versa. Patients arrive to a decision of management of their tumors for various reasons, as listed here, including the ANA support groups. However, a recent study, 500 patients, demonstrated that by far still physician recommendation seems to be one of the primary ways that patients decide on which management option to undergo, particularly for those undergoing observation. So then it's important to understand from a physician side, clinician side, that of course we need to really make sure that patients are taking part in the shared decision-making of what's the best management option for them. And there are potential barriers to this. As reported by physicians, of course, there are constraints of a busy clinical practice that may not allow for enough time to have a discussion with patients, or assumptions by physicians that the patient may not be interested in participating in their decision-making. As reported by patients, oftentimes patients report that there's inadequate time or provision of information for making an informed decision. And also, sometimes patients lack the knowledge that they should be participating or be involved in their decision making. What does this all matter? Because once again, studies have demonstrated that decisional conflict overall is associated with higher levels of decisional regret down the line. And particularly a recent study of 500 vestibular patients of all sizes that were followed longitudinally found that there was a significant difference in levels of decisional regret in the surgical group, as well as surgery plus radiation multimodality, as compared to the observation group. The surgery and radiation group fared equally. Observation, radiation, and surgery overall had acceptable levels of decisional regret, meaning the DCS, or the decisional regret scale, has a cutoff of 20, let's say 25 points. Over that is considered having significant degrees of decisional regret. Under it is acceptable degrees of decisional regret. All three management options, observation, radiation, and surgery, scored below that level, which at least was very promising. However, the patients in the surgery plus radiation group scored above it. So overall have significant degrees of decisional regret. So finally, as we come to towards the end of the talk here, I wanted to just briefly mention the latest quality of life instrument that has come out by the Mayo Group, called the Vestibuloceanoma Quality of Life Index, which attempts to really take all of this into account that we just discussed. The fact that the PanQOL may not be weighing appropriately the subdomains, and perhaps there should be more attention paid to headaches, pain, dizziness, and also incorporates separate part or set of questions looking into the level of decisional regret in patients. And this was just recently published last year, about the validation of the questionnaire, which I expect will be very, very useful to study further patients and understand a little bit more about differences between these management modalities. But what does it all come down to? So I think that in general, where we are today, outcomes of hearing, facial function, even dizziness, and headaches, as they stand, I truly believe we're probably not going to be able to make a major drastic difference in those outcomes between the management options. And we're never probably going to see one strategy reflected as the superior strategy, but it all needs to be very individualized for each individual patient. And beyond that, I do believe that I think a lot of what comes down to quality of life is also just having patients understand appropriate expectations, what the outcomes are. And so I think there's a lot of room for improvement in that sense, in providing patients with adequate education during that initial phase of their new diagnosis, where there's high levels of anxiety, and guiding them a little bit better through this complex decision tree of how to decide which option is best for that individual patient, taking into account all kinds of things, including family support, maybe upcoming important events in their lives, to try to decide which management strategy is best for them. And also so that when some of these inevitable outcomes, such as, some degree of dizziness that persists, or some headaches initially, et cetera, when they do present themselves, the patient is aware that they should expect this, and that it can get better, and overall improve their quality of life, as they perceive that they're going to get better over time. So with that, we're trying to actually, in our institution, Mount Sinai, look at an intervention in providing patients with a separate educational material in the form of a video format after their newly diagnosed vestibuloceanoma consultation, in order for them to go home with their family members, sit and try to review all this information slowly, and see if we could actually have an impact on some of these quality of life measures and decisional conflict and decisional regret down the line, as patients navigate this complex world of three different management modalities. So I hope that was educational for you guys. I know that we're pre-recording this, so if there are any specific questions regarding the content of the lecture itself, feel free to reach out to me at any moment. I'm happy to answer any questions. And these are my reference slides, but I'll leave this up for any questions.
Dr. Perez, thank you so much for that great information. We do have a few questions that came in beforehand, and actually some that you answered with your information during. If you want to go ahead and stop sharing your screen, we'll also share that information there. Awesome. So a couple of questions that came in. We hear a lot from patients about 24/7 headaches, which you touched on about headaches post-treatment, but also some tenderness that forms in the head and skull area, and even some patients talking about that going down their shoulder into their arms. Can you talk a little bit about that and kind of what patients may be able to do to alleviate some of that tenderness and those 24/7 headaches?
Yeah, of course. So as I mentioned in the lecture, I mean, we're starting to understand. I mean, it's interesting because we probably knew this all along, that patients that undergo craniotomies are supposed to have headaches, right? I mean, and there's been a lot of research into also looking at the different surgical approaches, as some of you may be familiar with, translabyrinthine approach, retrosigmoid approach, whether one carries higher incidence of headaches versus another. But overall, when you perform a craniotomy, you're at risk of developing post-craniotomy, post-surgical headaches for various reasons, right? And so it's, again, important, as I mentioned, to understand that that's the expectation, that this is okay, and understand that in the great majority of patients, as I presented in that slide, it will get better within that that first year, 1 year out from surgery. Some may require some higher degrees of medication, from going from non-steroidal high dosage of, let's say, ibuprofen, to perhaps some medications that are stronger, like gabapentin medication for neuropathic type pain. And then those types of radiating pain, oftentimes can be related to issues with occipital neuralgia. So when we make incisions in the back of the head for the craniotomy, oftentimes we irritate these nerves in that area, as well as muscle that gets essentially cut to get to the access for the craniotomy, that also by itself creates pain. And those muscles, have a trajectory. You could get referred pain or shooting pain from irritation of that area. And so, yeah, I mean, it's important to really have a discussion, and really important to discuss this with your physician postoperatively. Hopefully, you're going to see that we're all trying to incorporate more these questionnaires to really get a better assessment of what that level of disability is for each patient, to try to provide them with resources that are available. So there are pain specialists that help us manage these types of postoperative pain when simple medication may not be sufficient. And so patients see appropriate specialists to help manage that type of pain. But yes, I mean, all of this is expected, unfortunately, with surgery.
Awesome. And one last question. We have some people who come to us talking about delayed facial paralysis issues after surgery. That may be the day or two after surgery. They seem okay, but it has almost like a delayed onset the next few days after that. Can you talk a little bit about that and what a patient may expect with that, and maybe some things they can do to alleviate that?
Yeah, the good news is that delayed facial paralysis, in almost all cases, has very good prognosis. So, the main thing is to be reassured that, especially if they wake up with a pretty good function, that tells you that the facial nerve is anatomically intact, right? So our biggest concern is if the nerve has been severed or, significantly damaged, where there's a conduction block that is irreversible. But if you wake up with function, that tells you that it's there, and it can occur. I mean, there's some swelling, sometimes packing material, maybe some blood clots that are around the nerve itself. The nerve is just irritated from oftentimes multiple hours of dissection right off the nerve of sometimes very large tumors, etc. And so the good news is that yes, there's a good prognosis overall. In terms of what can be done, there's uh, important to understand things that you should be careful with. So people will discuss trying to do some sort of facial nerve therapy with electrical stimulation and these kind of things. Those in general are dissuaded. That can lead to actually more harm than good. But there are exercises that can be done to try to stimulate the muscles of the face and get the nerve moving. One thing I like to talk to patients, and I actually learned this from one of our facial plastic surgeons that specializes in facial paralysis reanimation, is to try to watch something that makes you laugh, and just you'd be surprised how just that instinct of laughing can get you to practice moving your face more so and slowly have you recover your function. And the most important thing is also, again, the eye function, right? So when we think about facial paralysis, that's probably, I would say, the biggest concern, that if you have a degree of paralysis that doesn't allow for proper eye closure, that your eye can be at risk of injury to the cornea, particularly at night while you sleep. If you sleep if your eye is open, you could scratch your eye, or maybe it could get too dry and develop a corneal ulcer. So during that phase where you're waiting for the function to return, important to perhaps see an ophthalmologist, get some close follow-up, make sure the eye is receiving good care with drops, perhaps taping it at night to keep it closed. If that phase is extended, we could even do a reversible procedure, like putting a gold weight on the eyelid that allows for better closure of the eye. But I think that's sort of our biggest emphasis, is eye protection during that phase of facial weakness.
Well, Dr. Perez, thank you so much for your time and all the wonderful educational information you shared. We'll be sure to send that information out. And thanks everyone for tuning in at anausa.org. And Dr. Perez, thank you again for your time and for Mount Sinai, everything that you do with the ANA and for the acoustic neuroma community as a whole.
No problem. Thank you, guys.